Yeah, thank you for the invitation. I feel honored to close this day, and I try to be fast and not to bore you. So the topic of my talk is lung transplantation after ex vivo lung perfusion. And what I try to find out is the quality of these reconditioned organs as good as the standard ones? Let me declare that I don't have any conflict of interest to declare and then go into the topic. So lung transplantation is the only chance for patients suffering end-stage lung diseases for long-term survival. And the biggest issue in this field is that you can use only approximately 15 to 30% of the available donor lungs for transplantation. And to expand this usability, the ex vivo lung perfusion has been established for marginal donor lungs. There are 3 different techniques used worldwide, the one from the Toronto group, the one from the Lund group, who were the pioneers of this procedure and invented it to clinical use. And there we have the 3rd technique, it's the organ care system. They have differences in the equipment that they use, in the perfusate composition, and in their perfusion and ventilation strategy. Unfortunately, I cannot go to the details because it is actually very interesting, but we don't have time for that. The research question of the study was, has a pretreatment of donor lungs with ex vivo lung perfusion an impact on the early clinical outcome after lung transplantation compared to lungs conventionally transplanted? And when you have a donor organ that is fitting the standard criteria, as you see, then you are very lucky and you can go the standard way, which is called and known as cold storage. And I think that most of you who are working with transplantation, they know this procedure. It's a cold flush, anti and retrograde with extracellular solution after the explantation of the donor lung. And then you store the lungs at 4 to 8 degrees, half inflated with a fraction of inspired oxygen of 50%. And then, of course, you try to keep the ischemic time as low as possible, but it is not so urgent as it is with hearts, for example. To come to the ex vivo lung perfusion, the goals of this system or of the procedure, as I mentioned in the beginning, is to increase the number of usable donor lungs by reconditioning and reassessing them when they are primarily rejected for transplantation. This procedure, it offers you a safe usage if you have doubts about using a lung for transplantation. And in the end, last but not least, what we want to do is to decrease the mortality on the waiting list, because this is a big issue talking about lung diseases. The key points of the ex vivo lung perfusion is the simulation of the physiologic in vivo situation, ventilation and perfusion of a normothermic lung. You can recruit atelectasis, which is one of the really most important things when you talk to experts. You can recondition under physiologic circumstances. You can reassess in peace the organ function. You have the opportunity of bronchoscopic clearance. You can remove pulmonary thrombosis, although these lungs are not considered to be the best donor organs, but there are some case reports that performed this very successful. You can improve microvascular circulation by reducing pulmonary edema, and you can offer for the lung recovering by simply preserve a normal metabolism. The concept of the procedure is, as I said before, reconditioning, which is done through a perfusion with oxygenated steam solution and ventilation. 2 of the used techniques, they use also red blood cells in the solution. But as I said, I can unfortunately not go to these details because there is lack of time. So after rewarming the lung, you can start reassessment of organ function, and doing this reassessment, the lung is perfused with a deoxygenated solution to imitate the venous blood composition in the pulmonary artery, because you want to find out if the lung can do the job that it is supposed to do. And the values that you want to reach is PO2 of 40 kilopascal or more when you have a fraction of inspired oxygen of 100%, or a PO2 of more than 30 with a FiO2 of 21%, and at the same time a CO2 less than 6 kilopascal. And when you measure values like this or better, you can accept the lung and transplant them. It depends on the center what is happening to the lungs after this decision. There are some centers putting the lungs back to the cold storage, and some centers, they just keep the lung on the circuit perfused until the recipient is ready for the implantation. So going to the study, what we did to answer the research question was a systematic literature review that finalized in the selection of 11 clinical trials published between 2009 and 2015. They were all case control studies or simply cohort studies, because it is from ethical reasons it is not possible to randomize these patients in the procedure. We identified two comparable groups. One group was the lung transplantation according to the standard procedure, and the other group was lung transplantation after ex vivo lung perfusion. We analyzed early clinical outcome, namely a post-operative ventilation hours, post-operative length of ICU and hospital stay, and the survival after 30 days and 1 year. We don't have data for long-term survival yet. There's only one study from Canada showing a 5-year survival, but it's the only one, and for that reason we just kept this data for 5 years out of this study. In addition to this literature research, I was asked to perform 4 interviews with experts, and again, I unfortunately cannot go to the details of these interviews, although they were, for me, very interesting and very inspiring. Here you see the selected studies and the data that were available, and here you see our statistic. And we couldn't find any significant differences between the two main groups that you see here on top, the EVLP group and the standard lung transplantation group. And as I said, no significant differences in the statistic. And what we did on top was to compare the different techniques. Here you see the Lund technique from Sweden and the Toronto protocol in comparison. And also here, there were no significant differences. And then we also compared the OCS protocol to Lund and Toronto. But from this OCS protocol, as it is the newest approach, there were not many data, so we cannot really take conclusions out of that. What needs to be discussed is that the ex vivo lung perfusion, it offers a reliable tool to expand donor pool for lung transplantation, and its safety and reliability were shown in different studies. But it is a very expensive procedure. It demands lots of time and requires number of specialist staff. The usability depends highly on the location of the transplantation center and the social and health system of the country that it is used in. As I said, we didn't find any significant differences between the different techniques, so all procedures seem to be comparable, and they also seem to be comparable to the standard protocols, and that's what also the experts in the interviews confirmed. For choosing a protocol, what I found out depends mainly on the individual motivation, as I saw that from the Scandinavian countries, they all go to the Lund technique, as the Lund group is from Sweden, and worldwide the trend is more going to the Toronto technique, but we will see what the future is bringing for this technique. And in conclusion, I can say treatment of donor lungs with ex vivo lung perfusion has no negative impact on the early post-operative outcome of the lung transplantation. If it has maybe a positive effect, we cannot say nowadays, and we need more investigation about that. And by the way, the number of available and usable donor lungs increased after the implementation of the program. It is in average 20% for the hospitals that introduced this technique. So I think we can do something good for the patients with this procedure. Thank you for your attention, and have a nice evening.
Thank you.